Kia ora and welcome to Goodfellow podcasts. This episode is kindly supported by the Royal New Zealand College of General Practitioners, the Auckland faculty. The content of this podcast was developed independently and the views expressed are those of our expert speaker. Today we're discussing concussion assessment and management and the updated 2024 ACC Concussion Guidelines. We're joined by Dr. Stephen Kara. Stephen is a sports and exercise physician at Access Sports Medicine in Auckland. He has a background in general practice prior to transferring into sports medicine. His previous experience has included rugby union at provincial, national and super rugby levels, as well as New Zealand hockey, Paralympic and Commonwealth Games. He is the current medical director for Canoe Racing New Zealand and will form part of the core medical team at Paris Olympics this year. He's an independent concussion consultant for World Rugby and the NRL. His interest in concussion is generated from his time involved in contact sports and has led to research with several publications, an education role, and guideline production for ACC and High Performance Sports New Zealand. He is the lead for the current ACC Concussion Guideline project. Kia ora, Stephen, and thanks for coming back onto the podcast.
Kia ora, Louise. Thank you very much for having me.
So today, the new New Zealand 2024 Concussion Guidelines are what we're focusing our discussions on, but can we begin by exploring how concussion is defined?
It's got quite a complicated definition, really, and the definition is a transient disturbance of brain function, essentially, which, if you look at that, you break that down, transient means the majority of people get better, and I think that's kind of sometimes lost in the media, that the majority of people do get better. And it's a change of neurological function. So from a structural perspective, there's nothing to see in the brain, and that's why imaging often doesn't help us, because there is no bleeding or bruising or swelling going on in the brain.
So is a concussion always caused by a severe force to the head and result in loss of consciousness?
So it doesn't have to be an impact to the head per se. It's a transfer of force to the head. So that can be a direct contact, like we see in sort of contact-based sports, where head versus knee or fall and head versus concrete. But it can be an indirect result. So, for example, somebody is hit in the chest area and that's sort of a whiplash type mechanism where that force is then transferred to the brain, and then you get those changes of brain function. And if I think about it, the way I like to explain that to my patients is, if you think about the brain, billions of cells, and essentially a cell is a bag of water with some substances inside, and that cell or that bag becomes a bit leaky because of the shearing forces, and because of that, then you get a transfer of chemicals down gradients, and that's what then changes the brain function. So the majority of the time, it doesn't have to be a direct head impact, and certainly only 10% of people actually have a loss of consciousness, so 90% of people do not present with being actually knocked out as such.
Are there any individuals who are more at risk of concussion?
Yeah, there is. We know that the adolescent areas is a little more high risk and have some risk of more protracted or prolonged recovery. There's more evidence sort of emerging around gender, so females having a more protracted recovery from concussion. There's also a genetic element, and there's a gene called the apolipoprotein E4 gene, which nobody tests for, but we know that is, if you're positive for that, then your threshold for absorbing that force is a lot lower. So traditionally, if I think of boxers, the terminology was they had a glass jaw, they couldn't take a punch, and probably those people had this ApoE4 gene that then predisposed them to having a lower threshold to absorbing force. So you've got the sort of the biological, and you've got the genetic factors, and then you've got those people who may have had previous episodes of more prolonged or protracted recovery from concussion. And we know that, unfortunately, past generally dictates future performance, and so they're more at risk themselves. And then we have those people who have got a concussion. There's certain factors in their concussion presentation which make them slightly more at risk of more protracted recovery. Those people tend to have a higher symptom load or symptom burden. They tend to have cognitive or vestibular dominant symptoms, or they have vestibular dysfunction. So those things from the actual clinical presentation again lead to being a little more high risk. So we've got biological or genetic factors, we've got past history, and we've got current presentation.
Wonder if we can move on now to management, and there's an acronym, the 4Rs. So can we start with the first R, which is recognise? How do we recognise a concussion? What are the visible cues, signs, symptoms, and what are some memory questions we should be asking?
So the first thing about recognise is these are for community-based sport, and I think it's everyone's responsibility to look for these. I think if you're the coach, if you're a teammate, if you're a spectator supporter, if you're the parent of that person or that child playing sport, then I think we all have a responsibility to recognise that. So the first part of the recognition would be a plausible mechanism, right? So we often that's lost nowadays, I think, in translation. Every time somebody touches their head, everyone gets, it's deemed that they must have concussion. You have to have a plausible mechanism. So coming back to that force, right, in terms of a big head contact, a significant fall, etc., leads to that plausible mechanism of force. So that's the first thing is we need to recognize. And then there's certain signs that, so for example, you think of the very, I guess the corollary and the easy thing to think of is just imagine a drunk person, because that's sometimes what that looks like. So, very slow to get up off the ground, clutching their head when they get up, wobbling all over the place, which are often, like I say, common signs of excess alcohol intake, are very similar to concussion, because the underlying pathophysiology comes back to that leaky cell that we talked about earlier. And then things like just, your children or, your teammates, so blank or vacant stare, asking repeatedly the same question again and again. Those things kind of all lead us to kind of saying, look, this is most likely a concussion or this transient disturbance of neurological function. And therefore those people should be, the next part of the R's is removed.
So how do we assess memory on the sideline, if we're on the sideline?
Yeah, so I don't think you should, right? I think those clinical tests are for those people who are involved in professional, semi-professional sport, where there's medical support that is part of the team's makeup. I don't think memory, testing memory on the sideline should be done, because it's not going to lead to anything else. It's not going to try to get that child back on the field or that person. I think if you've had to remove them because you were suspicious enough, then that's enough for me. I don't think the clinical tests that we have in professional sports should be in the community themselves. If you wanted to test memory purely for your interest, or maybe to relay that information onto a medical person at a subsequent visit, then there's some things called the Maddox questions that we use, and that generally 5 questions. There's 3 that pertain to the current situation or current sport or current level of activity, and they may be simple things like who are we playing today, where are we playing today, who scored the last goal, things like that. And then there's 2 questions that pertain to the past. So again, relevant to the sport that person is playing. So for example, if it was an equestrian rider, they say, where did we last compete, or who won the dressage last week, or who won the show jumping last week, or whatever that might be. So 3 questions pertaining to the current situation and 2 pertaining to the past.
Before we move on from recognition, are there any red flags that we should be aware of?
Yeah, I think that is part of that responsibility of all. I think if someone's recognised and they come off the field, then there's a series of red flags, and we'll kind of get to those on the remove. On the field, the red flags for me are prolonged loss of consciousness, and they talk about sort of greater than 5 minutes, and that's a very, very, very long time. There's obviously neurological signs, so sequelae, so would be those people who present, with altered sensation or neurological symptoms in a unilateral nature or bilateral nature. That's not a concussion. That's, a significant spinal injury until proven otherwise. Someone who has obviously seizure-type movements, tonic-clonic posturing, again, those things are a normal part of the concussion presentation, but I think they need to be referred through to a hospital and be adequately assessed before they're just put down to the concussion themselves.
Excellent. So on to the next R, remove the player from sport. So how quickly does that need to happen?
Immediately is my response to that. And this is supported by some nice evidence, a nice paper a couple of years back which basically looked at the symptom load and how symptomatic people were and how long their recovery was related to time being on the field post-injury. Those people that were removed immediately, no surprise, had less symptoms, got better quicker. Those people who were removed sort of less than 15 minutes post their injury, they had about 5 times the increased risk from those people removed immediately of having higher symptom load and taking longer to recovery. And if you were greater than 15 minutes, you had 12 times the increase in terms of symptom load and time to recovery. So, for me, I think the literature tells us that's immediately as soon as you recognize it.
Right. And dealing with an unconscious player on the sideline, what needs to happen here?
Just go back to your ABCs. I think if you've got an unconscious patient, you need to look for airways and you need to manage the cervical spine, because you have to remember the brain sits on top of the neck, and so therefore we have to assume there's a cervical spine injury until proven otherwise. So I think airway and management of the cervical spine by some sort of C-spine immobilization procedure, which can be, if those people have been through various courses, a thing called manual inline stabilization, where we just lie behind the player and support their neck in that position. And then you ABCs, okay, look after the airway, look for breathing, look for circulation. Those are the things that we need to do.
Just before we move on from removing the player, if someone's been removed in a game, should they ever go back into that game?
No, not in community sport, 100% not at all. It's a community sport. We love our peers and we love our children to play sport, but their brain, they get one brain, and their brain primarily is going to need to be used for getting education or go to work. So therefore, recreational sport plays a second fiddle for me. So no, once they're removed, they don't go back on.
Fantastic. Thank you for clarifying that. So we're moving on to our third R now, which is refer. And I wonder who we're referring to.
There's been an explosion of concussion, as you quite well see and understand from a media perspective. And so there's a lot of kind of worry out there. So there are a lot of people presenting. There's been some work with ACC around a pilot project looking at primary care and how we can support primary care, because I think it's probably one of the things that scares some people about, oh gosh, what do I do? And then we really don't have a lot of teaching in this sort of, well, when I went through an undergraduate or postgraduate stuff around, about concussion at all. So there's two ways, really. I think there's the BIST tool called the Brain Injury Screening Tool, which was developed in New Zealand by Alice Theodham and her group at AUT, is very much a GP primary care focused tool that can be done in 6 to 8 minutes, and it's validated against the traditional, what we call the SCAT or the SCOT or whatever else you heard from the Concussion and Sport group. And it really looks at what I call risk stratification. So it takes those people as a series of questions around looking for those people that need to refer to emergency department because they've got high risk for possibly having an intracranial pathology and needs to be reviewed there. There are the second group of people who are deemed to be high risk of a more protracted recovery based on the questions they answer and also their symptom load. And so those people we know do better with earlier referral to a concussion service. And then those people who are deemed to be lower risk, who are suitable to remain in primary care. And those people will then be progressed under the guidance of a general practitioner and physiotherapists, community-based physiotherapist support into, again, more exercise, more cognitive loading with clinical recovery, generally occurring within 2 to 4 weeks.
Can I just pick up on that BIST tool? So when is that done and is it repeated at certain intervals?
Yeah, so it's done on the initial presentation, and certainly the pilot project was funding that, and like I say, hopefully that is being evaluated now, and I'm hoping that will lead into a more national program where the funding will continue, but we'll keep our fingers crossed on that. But certainly done at the first presentation and then repeated each time the person comes back, and the symptoms are the key because it's a nice objective way of the patient scoring their symptom load or symptom burden, or how symptomatic are they, and you should see a gradual reduction in the numbers so that they're becoming less symptomatic as they clinically recover. Again, it's a nice, useful tool because if you're not recovering within the sort of expected timeframes, or their symptom loads going up, and then again, recognition of those people early and referring them off to a concussion service is probably the appropriate thing to do.
Great. Thank you for clarifying that. So moving on to our final R, which is recovery or recover. What are the general principles of recovery?
So recovery for me is split into a couple of phases. The first is that relative rest, the initial sort of 48 to 72 hours. That's just generally means people just take it easy, but they do normal stuff. You don't go and decide that, I was concussed playing football, but I can go the following day and go all my swimming training with that I normally do. Or that all those chores I've been left doing, I'm going to go and chop that big pile of wood, etc. So relative rest over that first 48 to 72 hours. Just do normal activities of daily living. If that means choose a short walk or with the family and things, and that's perfectly okay. And then we really need to look at, and this is the crux of concussion recovery management, is controlled cognitive and physical loading. So if we break that down, let's say controlled physical loading, that actually means doing some light aerobic exercise. Aerobic exercises where you increase your heart rate, and it's generally through the things that we associate with aerobic exercise, such as walking, jogging, sitting on an exercise or a bike, things like that. Not resistance-based training. Resistance-based training just is one of the things that can be more provocative in the early stages because it raises the intracranial pressure, because often we're doing a Valsalva maneuver to try and sort of, force the weight through that range of movement with our muscles. So it's aerobic exercise, and I like people getting moving really early. Now, why do we want to do that? Is because exercise is known to produce a hormone called BDNF, which stands for brain-derived, which means it comes from your brain. Neurotrophic, which means nerve repair, and F just stands for factor. And so you make that through exercise. You don't get that through sleep or nutrition or supplementation. Exercise is the thing that makes it. And it correlates really well with heart rate intensity. So the higher your heart rate is, then the more of it you make. So we'd like people to start with light aerobic exercise and slowly progress that, providing it's not making them more symptomatic than when they started. Because we don't want people to become too symptomatic because they just don't want to do it then. All right? But we want them to make as much of the hormone as they can without making them symptomatic. And so early aerobic exercise in a controlled fashion. And like I say, that can be any form of aerobic exercise. And then controlled cognitive learning. So the same sort of principles is using your brain. Can you go back and do a little bit of schoolwork? Absolutely. Can you spend a little bit of time on the computer? Absolutely. Can you spend time, the hobbies I like doing, playing my music or doing, some wood turning or whatever that look like? Absolutely. But it's in a controlled fashion. So again, we ask people to monitor their symptoms, to use a simple visual analog scale and say, how do I feel before I start? And rate yourself out of 10. 10 is, I feel terrible and I feel like I'm going to die. 0 means I'm a super person. There's nothing wrong with me. Wherever they score themselves, so long as that doesn't increase by +2, or +3, then we know that, again, that cognitive learning, what they're doing is controlled. It's not making them worse. And if it does increase by that +2, +3, then they stop at that stage. And for me, then they just look at their watch and or their phone and say, well, I was actually doing let's say the computer for 30 minutes and my brain didn't like that, but it was okay at 20 minutes. So therefore I come back to working at 20-minute intervals. So it's all about controlled cognitive and physical loading. That's the key in those early phases.
Thank you for clarifying that for us. So then when do we advise someone to return to sort of normal work and sports training?
Yep, so use symptoms. So as you're kind of monitoring their symptoms through the BIS scores, and they should be going down, and people are feeling better, they're increasing their aerobic activity, the scores might have been sort of stay at home for the first few days, but doing schoolwork at home. If we take that controlled cognitive learning, it's not being at home and not doing schoolwork, it's doing it in your own time, progressing them back into sort of half days, and then we're tolerating that, progressing them back into full days. And you just use their symptoms to kind of guide through that. Once they're back into sort of, full pre-injury exercise and back into normal work or school, whatever that may be, then that's when you're getting back into what I would call full clinical recovery mode. And it is that stage that we can then look at returning you to more sports-specific training.
And what is the earliest time period that you could expect someone to return to competitive sport?
Yep. So the new ACC guidelines launched this year make it really simple. I think they make it really simple for primary care practitioners because you only have to remember 2 numbers. The first number you have to remember is 14. And so you have to be 14 days of having no symptoms. So being back to normal before you can start sport-specific training. So that means before you can go back and start training with your team. Okay. And then 21 days is the second. So 21 days post-injury is the earliest that you could return to competitive-based sport. So if you keep thinking of two numbers, so 14 and 21, then those are the two numbers that we need to remember.
Magic. And then prognosis. So what is the prognosis following an episode of concussion?
Yeah, so we did a study back in 2020, which was published in the Clinical Journal of Sports Medicine in a New Zealand-based population. And we showed that 45% of people recover within 2 weeks, around 70%, 77, I think it was, percent of people recover within 4 weeks, and 94% of people recover within sort of 8 weeks. So you can generally expect on the majority of people, if you got that 80% mark, most people will recover sort of within that 4 weeks post-injury, and that's kind of normal. If you're outside of that, you're still within the bell-shaped curve to me, right? And if primary care practitioners are comfortable that things are improving, but they're just taking a little bit longer, then it may be, it might be up to that sort of 8-week mark.
Great. So to conclude our podcast today, your top take-home messages for our listeners.
So I think it is, the first one would be recognize and remove early, because that improves recovery time. And I think that's a responsibility of everyone. It's not just the referee. It's not just the coaches. Everyone's responsibility to do that. The second one for me would be early controlled physical and cognitive loading. That's the key to early recovery. And hopefully my explanation of that wasn't too complicated and people could understand those general concepts. Third one for me was use the BISC tool, because I think it is then at risk stratifies your patient. And I think at primary care level, it may just make it easier for you to know this is the person is likely to recover within sort of that 4 week time frame. This is the person that is unlikely to recover, and therefore I should refer them off early. Then most people recover. So it's inside of, so I sort of said 3 months, because we know that actually the numbers are really high by 3 months, that most people will have recovered by. And the last one is, for me, is concussion recognition. And the appropriate return to play is everyone's responsibility. Like I've said before, it's not just a medical problem. We need to liken this to the drink driving campaigns we have out there and say concussion at a cellular level is the same as an alcoholic brain, and society takes responsibility for that. I think we need to take responsibility as a society to ensure that my whānau, my teammates, my children and my mates are all recovered before I'm asking them to play sport again.
Yeah, some really great points there. Thank you, Stephen, for sharing your expertise on this important topic. A list of resources will be found on our website, goodfellowunit.org. Thanks for listening.